I think there has been an evolution that we've all seen and have in fact promoted and are happy to see occurring in this disease state, whereas for many years the pivotal trials for new therapies relied on these functional endpoints, and a typical one was the 6-minute hallway walk test or the 6-minute walk distance. And it was, in some people's mind, a direct measure of exercise on a certain level because they were walking, but many considered it really a surrogate endpoint for the things we were more concerned about. How functional were you, and how did that give you a risk of other events down the line? We sometimes also use something called time to clinical worsening. The idea behind that was we were not looking at mortality endpoints in the long range, so how likely were they over perhaps a 12 or 16-week period to experience an event such as hospitalization, which we would use as a marker of worsening. Where the field is really shifting towards with newer trials now is to measure morbidity and mortality endpoints much more directly. The meaning behind that is that these tend to be longer trials, so we're not following patients for just a few months, but we're following for many months, up to a couple of years in some cases, and we're looking at over that time how likely are they to experience the actual event of interest. Does the medication presently reduce the risk of dying from this terrible disease? Does it reduce the chance of being hospitalized because it keeps them more stable? Or are there other morbid events, such as needing to go to lung transplant, or having to have further procedures, or having to have other add-on medications that we'd all consider something we wish to avoid? So in the whole, I think we're all very excited to see, as the understanding of the disease evolves, this evolution in endpoints that took us from really more basic functional endpoints to those that are more impactful for the patients.